Hi and welcome. I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Joining me today to discuss tips for success in emergency medicine residency is Dr. Amy Ho, an emergency physician and also a member of Medscape's advisory board for Medscape Emergency Medicine. Welcome, Amy. It's really great to have you join me.
Thanks again for having me, Rob.
So preparing for success in emergency medicine residency really requires careful planning, especially in the age of a plethora of informational apps, digital technologies that we all know about. But it also involves anticipation of the needs of patients, finding hacks to maximize efficiency, and most importantly, developing a great rapport with all members of your team in your emergency department. So there was a recent Reddit thread that my editor, Anya Romanowski, had sent to me, and it brought back thoughts of our prior interviews in which you had explained MacGyver-like techniques, actually, as approaches to patient care challenges in the emergency department. I was hoping you could share a list of procedural and informational approaches and hacks to help ensure success for those entering emergency medicine residency in the spirit of MacGyver and also the Reddit thread. One of the first things you and I had spoken about is that emergency medicine is a team-based sport. You got to treat your team well, and I'll let you, go from there.
Yeah, absolutely, Rob. And I love this topic because it's really the art and the style part of being an emergency medicine physician. And, you mentioned this is great for residents, but I think it's great for anyone practicing emergency medicine, not just residents, not just if you're new at a job. So you're totally right. EM is a team-based sport. On the Reddit thread that you referenced, actually, the number one tip was not something medical at all, but it was definitely don't date your coworkers, which I will not comment on. But I do think there is a lot in terms of the team. So know who your team is and respect them. So introduce and acknowledge and thank everyone and try to learn their names. Now, this isn't just your nurses and techs, but also scribes, chaplains, RT, the radiology tech, environmental services, the police. There's so many people we depend on. And it means so much to acknowledge who they are. And I think with that also, it's not only acknowledging them, but also helping with all tasks. Nothing will fail you more in a department than the attitude of not my job. So help roll, help transfer, clean up if you have time, and always, always, always clean up sharps yourself from any procedure you do. That is just the fundamental safety point.
And one thing is, you mentioned knowing names. And obviously we all forget names, but knowing someone's name is really something that's very personal. And when you know their name, I think it makes them feel better. And that really, to me, shows respect. It shows that you're focused. And, I really appreciate you pointing that out.
Yeah, absolutely. I think it's just about knowing what the team members bring to the table, being willing to help, respecting them, learning, even parts of their trade and helping that, like I said, rolling, knowing how to turn off the beeping monitors and drips, getting a sandwich or a blanket for a patient. It's really about being considerate.
Right. It's not that it's not your job. Everyone pitches in. And when that happens, team building occurs naturally.
Yeah. And as you build rapport with your team, you just start to fly. Like they know how you practice, you know how they work. A lot of things just become natural. One of my big things is doing sensitive exams for patients all together. But as the staff get to know me, they know like, hey, if we're going to do a pelvic, like we'll all go together, we'll knock it out, we'll be done. And then the patient also only has to do it one time.
And moving on to apps, the number of apps is just exploding really by the week, by the month. And I would love to know what you think are the best apps going into residency and also for, attendings as well.
Yeah, so there are so many apps out there. So when I trained, we had lots and lots of cards, which we would have on our badge tag. And really, who doesn't have their phone on them all the time? So there's so many apps. Apps are only as good as you know how to use them. So I've broken this down into about 5 apps I think are really key. One is MDCalc, because we are the specialty of knowing very little and trying to risk stratify. So I think MDCalc is so core, but you have to know which tools to use and when. I think 2 is you need one core EM app. And there's a lot of them. There's MRAP Core Penium, there's Palm EM, there's Wiki EM. I think try them out and see what's natural to you and then just commit to that one. I think 3 is a EHR app, like for example, Haiku for Epic. It's just key to your workflow for like adding pictures, looking at the board, signing orders, etc. And I think also worth talking about now are AI apps. So ChatGPT, Open Evidence, but I mean, we literally have intelligence at our fingertips now to ask any question of, hey, what's the workup for X, Y, or Z? Of course, do not share PHI, but AI is really the future for references. And then lastly, I think our special emergency medicine apps, which I call things like ultrasound, Hippocrates for meds, maybe up to date, like full code, PD stat. There's a handful that might be really relevant to your practice. So just pick which one those are and again, get really familiar with them.
Right. Do you find that your residents are starting to use more AI right now in terms of really like that immediacy and being able to get answers? And the question is, are there too many hallucinations you're seeing from the AI in reference to, say, more specific things in emergency medicine, more nuanced things that AI hasn't yet caught up to?
Yeah, absolutely. So I see residents using AI a lot. I think the big danger is that if you're especially a new resident, you haven't built in the gestalt to be like, wait a second, that doesn't feel right. So I do always say for anyone, but especially residents, keep it all with a grain of salt. Anything that you're going to act on needs to be cross-referenced yourself manually to make sure that it is actually true. And again, not a hallucination. But I feel like as an attending, having AI as a reference is great because I'll read something as a response and be like, oh, yep, that totally cues. I just couldn't, get it at the tip of my tongue.
Absolutely. And you made a comment about discharge instructions, that if you're typing them in multiple times, you need a template. And so here, I'll let you expand upon that.
Yeah, so I'm actually an informaticist as well as being an ER doctor. So I love efficiency and workflow. And I feel like anything you're typing or clicking more than 3 times, you need to save as a template. So discharge instructions, if you're typing them more than 3 times, you need to save as a template like rice. Favorite orders or order sets with the instructions and the dosing, like I think you need to have saved as a template. And then same for things like MDM, if you have common differentials you always use for certain chief complaints, for HPI, because we do ask kind of the same questions over and over. I think all of those just let you fly out of notes in like 60 seconds.
Absolutely. Now, in terms of scribes, I don't know if you work with scribes or even if AI now is integrated into your EHR, but things are changing quickly. So scribes had been obviously the advance probably in the last decade, but AI now is coming into the forefront. It's not ready for prime time, in my opinion, but maybe 10 years from now, there may be a role. How do you see the role of AI in emergency medicine as sort of a hack, so to speak?
I mean, it absolutely is a hack. I think it's faster in 10 years. I think in 3 years, we will all be using AI. I know a lot of people using AI scribing platforms. There's ones that are released by EHRs. There's like a Bridge, which I think is one of the really common ones. And not only do they help you in terms of scribing, but they offer you some MDM. They give you kind of pearls to look for. You can customize them for cues for yourself. They're absolutely incredible. And I think that they will be a key part of residency soon because you have to know how to use these tools. I will just say, like, please, please, please do not use those tools without the explicit approval and rollout by your hospital because that is all patient data.
Absolutely. And you talk about using the ultrasound machine really in the midst of doing your physical and multitasking in this capacity. And sometimes it's difficult to do, but what's your hack for doing that? How do you do these things all together?
So I love ultrasound, as do most emergency medicine physicians. So I make sure that I actually do the ultrasound as I'm talking to the patient. They love it. I show them what I see on the screen, and it gives me some immediate answers on what's going on. Obviously, if I see cholecystitis, I already know the answer. I think also keeping a lot of that equipment really nearby is key. Like in general, I always have, a flush and an IV because you never know when you're going to do an ultrasound guided IV. And at the beginning of shift, like I'll grab one of these big pink buckets and just fill it with the supplies I think I might need, whether it's, bandages, if I'm working in urgent care area, if I'm working trauma, I'll have Dermabond, like all the common things that I might want for that shift. And then just having it near so I can just grab it and go.
Yeah, so if you spot a patient who has poor access, why not put the IV in, ultrasound guide, just do it ahead of one of the residents or nurses and just save that time. And that's an aspect of team building that I see, especially, working in the department, because if you're going to go ahead and be proactive, that says something about you. Absolutely.
And it's good for the patient. It decreases pokes, and it is procedurally amazing for getting good at central lines too.
Absolutely. And in terms of anchoring bias, at times, kind of fallen victim to this. And it's hard to fight this. You think something is quite obvious, but it may not be obvious. How do you deal with anchoring bias specifically?
So this was one of the arcs that I felt like I really went back and forth on in residency. There were times when I wanted to chart review everything before seeing the patient. There were times when I chart reviewed nothing and just went and saw the patient. And what I settled on is I like to do a really light chart review. I do read the chief complaint, I look at vitals, I look at meds and maybe their last office note, but I already know that I might have been anchored by a nurse, especially experienced nurse in triage on how they write the complaint. So I just keep that in my mind. And if the patient says something that doesn't quite sound like what the nurse documented or what's documented elsewhere in the chart, then I really try to explore that so that I mitigate my own anchoring bias.
And then I wanted to talk about Nastagram because you brought that up for the core measures. What's your approach in terms of avoiding the Nastagram?
Yeah. So this was always what I found most demoralizing is I'd work a busy shift. I'd feel great about seeing a sick patient. And then the next day I would get the nasty email from the quality department that said, hey, you missed sepsis by like 50 cc's. Like it was just so soul crushing. So for me, I think it's really important to identify at your facility what those big core measures are that are going to get you into trouble, whether it's sepsis, stroke, STEMI, trauma, open fractures. Those tend to be the big ones. And then I constantly think about it when I'm running my list. I look at, of course, the sickest. Then I look at the things that are in this Nastagram bucket. And then I look for all my other to-dos, things that will move dispositions and so on.
Mm-hmm. So how do you multitask and deal with, say, a family member and you have a sick patient? Do you tend to bring in, say, the resident or a nurse or even someone from the social work team that could help a family and you're in the midst of a crisis? How do you sort of nuance that?
So I'm with you. There's a lot of nuance there. I do always bring a social worker or case manager to just help because there's so much support that's needed, a chaplain. But I think that this is really the human side of emergency medicine. Like we are not just, quote, moving meat. We are really helping save lives, give support to families. And so there are some conversations where I think it really should take as long as it needs to take. Like telling a family about a bad outcome absolutely is something where I actually give my phone to someone else before I come in the room. And I tell them, come physically grab me if you need me. But I think I need to spend as much time as this family wants from me. And of course, there's other times when, you are going to bounce between rooms. So that is part of what you learn in residency, part of what I think you'll pick up of what it resonates with you as your style too.
One of the things I was taught was to sit down in a chair really helps. If you do it in a chair versus standing, there's a big difference. And I think maybe you can comment on that.
Absolutely. I mean, sitting in the chair is probably the number one tip we get from a patient experience standpoint as well. We do not always have chairs in emergency departments though. So I know right. I am known for sitting on top of trash cans a lot. Absolutely. Getting on the level of the patient or the family that you're talking to slows you down, puts you in the moment at a time when you really should be in the moment.
Right. Because these are serious issues. And if you spend that extra minute at their level, like you point out, they feel something, that your energy's there and that you're relating to them. And that really is worth a mountain of gold, in my opinion.
Yeah. And I think it's worth noting that like we go into the ER every day, every other day, whatever it is that our shift schedule is. So it's really normal for us to be there. But for most people, they probably don't go to the ER, but maybe once in a lifetime. And so it is a extremely important, vulnerable moment for them. And you're the one that is supporting them through it.
Absolutely. Are there any additional things you'd like to bring up that you feel that, merit, discussion at this point?
I think document well. I don't want to say document to CYA, but document well. Document what you said, document what responses were, document, what consultants said, their names, what family member said. It's not only a medical legal thing, but it also is a document that you're passing on to the next clinician that sees the patient. And I think for me, it actually helps me work through that thought process. So don't shortcut your documentation because of time. Sometimes it really, really matters.
What about copy and pasting? This has always been a big issue that I've faced, and obviously it goes on. And medical legally, there can be some aspects to this too because of things missed. What's your recommendation?
I usually do not copy paste. I think you run yourself into trouble. However, I do, again, believe in templates, but on those templates, I leave lots of clear blanks where I think I should contemporaneously, free text what it is that's happening. So I think note bloat is real. I also think copy and paste is hard to review sometimes. And I think if you are copy and pasting, maybe that information is not that important. Like maybe it already exists somewhere else. So I really like to spend my time on the free text part of it, like your medical decision making, the real-time ED course changes, those sort of things.
So one last thing I wanted to talk about is procedural sedation. We've all had a busy shift where we have a septic patient, we get a shoulder reduction, someone's screaming in pain, we want to get them medicated, we want to obviously use techniques that maximize our time. We may not need a full procedural sedation. There are other hacks, obviously, techniques.
Yeah, so something like procedural sedation, I think, is the definition of a team sport because there's a lot of moving parts. So I try to chop these longer procedures into pieces. So piece one is obviously getting all your orders and getting all the consents in, all the medications. I think that can happen really anytime as you're running between other patients. I think piece two is getting all the human resources together, and that's when you're about ready to start, like RT, X-ray after, right? We always forget about X-ray, splinting, so maybe having a tech ready to help you in case you have to run out, and obviously nursing, pharmacy. And then the procedure itself actually doesn't take that long, right? You push medicines, you do your procedure, you get your confirmatory X-ray who's already there, you splint them up, which you can have someone help with, but you need to be in the area in case there's any complications. So what I do is I try to save my charting to kind of come up to that point, and I'll grab a mobile computer or just be on the computer right outside the room and work on all of my charting while I still need to be within ear and eye shot of the patient, while the nurses and the rest of the staff, of course, help the patient as they're finishing up the splint, coming out of sedation, those sort of things.
That's great. Would you ever use ultrasound in place of X-ray, just say to save time and really confirm that the joint's been reduced, basically?
So I actually do love using ultrasound, but I think standard of care is still an X-ray. So for me, I personally still always wait for the X-ray, but I make sure that I ask the techs to be right there as I'm doing the procedure, so we're ready to go with the board in place and everything else.
Well, listen, this has been an excellent tutorial from an expert like yourself who is really very seasoned, efficient, and really knows the hacks and certainly the apps and the ways to relate to patients. I want to thank you so much for joining me and sharing your knowledge.